Yeah, welcome everybody to this afternoon's symposium where we are presenting progress on the EPIsoDE study. The EPIsoDE study started in March 2021, and as of now we have treated about 120 of 144 patients across both study sites here in Berlin and also in Mannheim, where the three of us are working. And since we don't have any final results or data yet to present, we thought we would present you today some of the challenges and hurdles that we've come along and try to answer how we've dealt with them. Therefore, the title, Trials, Tribulations, and Insights. Welcome to that.
Hello, everybody. It's a real pleasure for me to introduce Lea Mertens to you all. She's going to start. I'm going to quote what's on the homepage of the Insight conference regarding Lea, but I want you to know that Lea is much more than just those few sentences. Next to Gerd, I think she's like the driving engine behind the EPIsoDE study. And yeah. We're really grateful to work in this team together. So, Lea Mertens is a clinical psychologist and researcher. She received... Is it open? Okay. She received her Master of Science in Cognitive and Clinical Neuroscience with a specialization in neuropsychology from Maastricht University. During her master's, she worked at the Center for Psychedelic Research, Imperial College London. For her PhD, she has joined the Department of Molecular Neuroimaging, headed by Professor Gerd Gründer, at the Central Institute of Mental Health in Mannheim, where she is primarily conducting clinical and neuroimaging studies. Please welcome Lea Mertens.
Yeah, welcome also from my side, and thank you very much for those kind words of introduction. I'm also very happy to be here to speak about the EPIsoDE trial and some of the experiences we have made in the past 2 years. I think 2 years ago I promised, or we promised, that we would present some results. Unfortunately, we won't be able to do that, but I'm pretty sure we will still able to show and share some of the learnings we have had, and we're very happy to discuss them with you. So this is going to be the outline of the day, and I'm going to start with risks and ethical challenges of psychedelic-assisted therapy and research. And before I'm going to dive into that, I just want to get us all on the same page. For those of you who don't know what the EPIsoDE trial is about, it's a phase 2b trial on the efficacy and safety of psilocybin in treatment-resistant major depression. So what does that mean? We are treating 144 patients in total with 2 dosing sessions. And as you can see here, we're going to do that in a 3-arm parallel group trial. So 1/3 of the group gets a high dose in the first dosing session, 25 milligrams, whereas the 2 other arms either get a low dose, 5 milligram, or an active placebo. And then 6 weeks later, after assessment of the primary endpoint, there's kind of a post-primary endpoint crossover to ensure that all patients get at least 1 high dose, and those who've already received a high dose get another high dose or the low dose. So that, just as some background information, that's our study design. And then I want to talk about ethics and challenges. And the first question I want to ask is, why do we have to actually have to deal with ethics? And I brought a definition with you, what ethics actually mean. Ethics is the philosophical study of morally right and wrong behavior. And then we have the applied frame of medical ethics, and it refers to the ethics of the therapist or provider-practitioner-patient relationship, and it's supposed to help resolve ethical questions or choices about medical care. So I think it's quite obvious, ethical questions and medical ethics as a field is relevant to all medical treatments, and psychedelic treatments are no exception there. Biomedical ethics works with 4 principles, and one of the most commonly quoted principles are the 4 principles of biomedical ethics by Bouchon and Childress. And just as some background, like those 4 pillars, because I'm going to refer back to them throughout my talk, are autonomy, so the urge and the obligation to respect an individual's freedom to make their own choices about their health and their treatment. Beneficence, meaning acting in the best interest of the individual, providing benefit to our patients. The principle of non-maleficence, so to avoid harm, to avoid doing harm to our patients. And the principle of justice, meaning that we are supposed to treat all our patients equally with fairness and impartiality. And I think that that point also refers to having equal access to a certain kind of treatment, to have that equal as well, to be just in that respect. And as I've already said, ethical challenges and dilemma, and unfortunately also breaches, probably exist in all medical fields. So psychedelic science and psychedelic medicine is no exception. But what I want to point out and stress throughout my talk is that maybe some issues that we see in other therapies or in other psychotherapies might actually even be amplified in psychedelic therapy or psychedelic-assisted therapy. And the first topic I want to dive into is the topic of informed consent. So informed consent is the prerequisite for well-informed autonomous decisions. So it's the most important ethical principle in clinical studies, so to speak. But that also brings certain challenges and risks within psychedelic science. Because one question that we have that I'm asking, how do we actually give informed consent to a therapy involving an altered state of consciousness when, first of all, the effects, the acute effects, are super difficult to predict, very individualized, very much depending on set and setting. And second of all, if the altered state of consciousness is so ineffable, it's super difficult to describe in words, particularly the people who are naive to some sort of altered state of consciousness. And then the question, how detailed and informative should and can the patient information actually be? Because we kind of have two sides in that. We have the risk of inducing expectations and bias if we provide too much information. And we have the risk of unblinding if we're looking from a research side. But on the other hand, I think there's also a lot of agreement that not providing sufficient information is unethical, because how would someone be able to get to a well-informed autonomous decision without important information? And that what I also point here, it also depends on from what role we are looking at this. If I'm looking from the role and the perspective of a researcher, I might be torn to limit the amount of information I provide to reduce expectation and bias. But if I look from the perspective of a therapist, I might be willing to provide almost all information there is to ensure that my patient is prepared as well as possible. And then the next point being about study inclusion and treatment indication. And you can see here we are kind of have, again, 2 sides. The patient autonomy and justice. So every patient who actually wants to get their treatment should be able to get it if it's an autonomous decision, versus the other primary goal of practitioners to not create harm or to induce benefits in patients. So meaning if a patient comes to us and we would actually from an expert opinion say, well, no, we don't see that the treatment is actually safe and a good idea to do it, that might be in conflict with the patient, like the autonomous decision of the patient. And I think this is a perfect example of an ethical dilemma that's actually not solvable, because it means we cannot value all of those 4 as ethical principles the same way. We have to balance like which of them is most important in a certain situation. And the last point with regard to informed consent, what happens actually if the informed consent shifts under the influence compared to what a patient agrees to beforehand? And I will get to that in a second. The next thing I want to talk about is therapeutic touch. Just as an explanation, therapeutic touch is used as a non-verbal therapeutic tool for managing challenging experiences and providing corrective interpersonal experiences of support and care within psychedelic therapy. And there are certain challenges and risks to that as well. First of all, I think quite obvious, as with all psychotherapies, but more so than even with one that involves physical touch, there is the risk of inappropriate touch and sexual abuse with some sort of healing intention. But I think the challenges and risks not only start there at the extreme of the line, but there's also a risk of boundary violation and re-traumatization in patients who have maybe a history of sexual abuse without crossing these very strict boundaries of no sexual contact whatsoever. And on the other hand, there's the same risk of re-traumatization and the risk of neglect if you do not provide the therapeutic touch in an altered state when the patient would actually feel that they need it, or you miss an opportunity for healing experiences if you refuse from therapeutic touch. And I think one of the solutions that people come up with is the informed consent a priori. But I brought an example that simply shows that that's not the perfect solution, because informed consent can shift. And that's an example that actually happened in our EPIsoDE trial. I will just read it out to you as an example of an ethical dilemma. It was a woman, 32 years old, with a history of sexual abuse and a diagnosed treatment-resistant depression. During her preparatory session, her two therapists, as prescribed in the manual, one male and one female, discussed with her the option of using therapeutic touch in form of holding her hand and her arm. She agrees to this form of touch, but also asks for the therapeutic touch and the blood draw to only be done by the female therapist. During her dosing session, presumably a high dose of psilocybin, the female therapist had been holding her hand for a while. Once she gets up to prepare the blood draw and lets go of the patient's hand, the patient reaches out to the male therapist, explicitly requesting him to hold her hand. So what do you do in that kind of situation? It's super, super difficult, and I don't think there's a right or wrong answer, because it is an ethical dilemma. The third thing I want to talk about, very important, is power dynamics and risk of abuse and harm. This as well is not specific, obviously, to psychedelic therapy, but again, I think there's a potential of this risk to be amplified. With the power imbalance between patient and therapist simply being increased due to the altered state of consciousness, patients get into a state of increased suggestibility, emotionality, vulnerability, with some researchers and clinicians in the field even describing it as, they're getting into a regressive state. So the power imbalance simply increases. And that does bring the risk of power abuse and harm. Again, in the extreme of sexual abuse, for example, but it doesn't start there. One example that we also discussed in the team is that what if the often unconscious narcissistic needs of the therapist, for example, the need of the therapist to be the helper, to be the savior, a need for praise and compliments, actually influences the therapeutic process. And this can foster submissive behavior in patients, or it can lead them to actually praise the therapist as being the healer, bring them the healing pill, the healing psychedelic, because they are often in need for affection, and this power dynamic driven by unconscious needs of the therapist can then hinder the maturing of patients into their true self and detachment. And there's no clear solution for that, and it's not a challenge unique to psychedelics, but just one thing I want to point out is like kind of a paradigm of wait, meaning that you as a therapist always have to ask yourself, why am I talking? Also with respect to the theme of touch, why am I touching? So always be aware of your motives, of your intentions. And another thing I want to point out, especially with regard to this, because some of these things happen unconsciously, you as your therapist have to be, you have to have had your psychotherapeutic self-experience. And I specifically mean psychotherapeutic self-experience. It's not necessarily drug self-experience, but you have to have made your own process. And supervision and intervention is super important. And this brings me to the last thing I want to point out, and I think this point is the closest to my heart. And I simply want to point out that these therapists involve strong therapeutic relationships and intensive therapeutic processes. And especially in clinical trials, unfortunately with an established end date right from the beginning. And just to bring you back to our study design, if you look at this study from a pharmacological study perspective, to me it looks like a very simple drug trial. There are 2 doses, parallel group design, and we just see what comes out of it in the end. But in practice, it looks very different. In practice, this is not a simple 2-dose parallel group post-primary endpoint crossover design, but it's a 13-week therapeutic process, a continuous therapeutic process in which patients are. And those processes can be very intense. And with it being so intense, and with the established end date, come a lot of risks and challenges. And the first risk is simply the style of therapy. It's a therapy that is kind of a revealing or exposure-based approach. And this brings the risk of destabilization. It's part of the game, so to speak. It doesn't work without. But destabilizing a system always means there's a risk that you cannot hold the emotions or what comes out of the destabilization. The difficulties of keeping boundaries from the patient side. They might be so overwhelmed with what's happening in them that they feel they can contact you every day, at night, during the night, whatever. And that also brings the risk of over-involvement and over-identification with the therapeutic process by the therapist. I think this point is not stressed enough in the field, but this work is very intense as from a therapeutic side. And it has the risk of a high emotional burden on therapists, the risk of developing empathic fatigue by therapists, and in the long run, potentially situations like burnout. So it's very important to just be aware of that. Those are intense therapists, not only for patients, but also for therapists. Again, from the perspective of the patients, because of these strong, intense processes and strong therapeutic relationships, there is the risk of dependence and detachment problems if the trial, as in our study, ends after 13 weeks. And then the risk of re-traumatization when that happens. And I want to stress that because Manuela is going to talk about that a bit more. We're talking about treatment-resistant depression patients. A lot of them have adverse childhood experiences, adverse interpersonal childhood experiences. And redoing that by ending the strong therapeutic relationship could do more harm than good. And that's just things you have to take in mind when planning a study with a psychedelic. And the last point, I think we also touched upon that in the other talks we've had so far, is the oftentimes happening wish for post-trial psychedelic experiences. I think it's a very understanding wish. There's nothing wrong with that. It just means even those patients who might not have benefited numerically from our treatment have the feeling there is a potential in there. They got somewhere with it, but they are not done in their process after those 13 weeks. But we cannot offer them anymore. So what do we do? And it's super difficult to handle. And because we're also in this ethical dilemma and the legal situation that those substances are not legal. And we also don't think it's with the goal of not doing any harm, a good idea for all patients to do that, to do this kind of treatment themselves. But obviously they are autonomous individuals, so they can, which brings us again in an ethical dilemma. And again, we think the best solution we've got and we can offer is harm reduction. So informing them, helping them make an autonomous decision, but still being aware of our responsibility as therapists and providers to reduce harm. And this is an example, the last example I brought with me from a patient I was privileged enough to support during our trial of a very intensive therapeutic process. It's a quote she wrote me via email 4 days after her second dosing session, which was probably the high dose. And she wrote, "Feeling-wise, I would say I'm no longer in a very severe depression, rather a moderate depression. I feel better, yet the fear is still there. I feel the permeability, the sensitivity, and the associated fear very strongly. So the fear is still there. But these days I also notice that it's possible to feel the fear and to accept it. It seems to me that if I wanted to continue on this path, I would have to allow myself to fully immerse myself in the process for a few months. I imagine that further psilocybin sessions would help me to dive completely into my emotions, into myself, and to feel that this letting go into the feelings does not kill me, nor does it make me lose my mind. and to feel how my perception will lighten through accepting. I think there's a lot in that quote. I think it shows very, very valuable therapeutic insights, therapeutic experiences of acceptance towards her own emotions, but it also shows how challenging that kind of therapy can be. Which brings me to my conclusion. And the key messages of my talk as being, I think, as with all medical treatments, there are ethical challenges and the risks in the context of psychedelic-assisted therapy that need to be considered based on the 4 pillars: autonomy, beneficence, non-maleficence, and justice. Psychedelic-assisted therapy is not a pure and by no means basic pharmacotherapy. It involves intensive therapeutic processes and relationships that brings unique challenges and risks, particularly in vulnerable patient populations, such as treatment-resistant depression. And researchers and therapists in the field, as well as regulators, have to take this into account when planning, conducting, and approving future psychedelic-assisted therapy trials. And that's from my side. Thank you for your attention, and I'm happy to take some questions.
Thanks. Leah, are there any questions? Yep.
Thank you for this great presentation. I'm curious as to how you did set boundaries in the trial. Could patients call you? Would you pick up? What are the rules relative to that?
That's a very good question. So we do have a protocol, we do have a manual that actually says that we have the planned preparatory and integration sessions in person, and then we have weekly phone calls that are scheduled with the patients by their therapists. And everything beyond that, we do in a patient-centered way. So pretty much with a framework of, because we're still early in that kind of research, everything that needs to be done for safety reasons we do. So if a patient requests, I'm in a crisis, can we talk? Then we do react to that. And that's actually also one of my points, that this, in this destabilization phase, can create very extensive context of multiple emails per day in an extreme case.
Hi, thank you very much for a very interesting presentation, first of all. I was just thinking when you're talking about the, also the pressures of the therapist and that it can be very heavy work, like what are your sort of tips or like your ideas of how to deal with that? And like as a therapist, if, these experiences and the heaviness of it, basically.
Very good question. I wouldn't say I have specific tips. I just think you need to be aware of it. You have to, I think that's also something that is discussed in regular psychotherapy training, right? How to take care of yourself as a therapist. I just think that this is particularly important in that kind of work. Probably the same as with if you're working with trauma patient, because you're just taking a lot of load on yourself. And as I said, I think we do have a great team. We interact a lot. I think that helps. Speaking about especially difficult situations. And besides that, just finding your own ways of taking care of yourself, regulating yourself. I think the microphone is not working anymore.
Maybe now again, right?
Yeah.
Follow up?
I'm just thinking, is this also something like you're doing all these studies and obviously you're doing all this work, like is this something that's being discussed as, do we need like a framework for these kind of like working as a psychedelic therapist maybe in the future? Like, do we need like a framework for how to do that sort of thing, if you understand what I mean?
Yeah. Well, I would think we do, yes. I wouldn't say it's I totally agree with the statement of psychedelic therapy being psychotherapy. So we know a lot from psychotherapy, and I do think that regular psychotherapy training teaches you a lot for doing psychedelic therapy. But yeah, some things might be a bit different, or just stronger, and yeah, there has to be awareness for that, and there has to be room to teach that to future therapists for sure.
Question? Yep.
Looking at the last quote from the patient with the depression, I think it's very obvious that a patient who is suffering for years from a depression and now sees a way out, want to continue on the way. Have you thought about a cooperation with centers in countries where it is legal?
I would not be aware of countries where that would work. So for example, in Switzerland, which would be a wise choice for German-speaking participants, you can only get that kind of treatment if you're living in Switzerland. So that's not an option. So we don't have a lot of options there.
We have time for one more.
So thank you first of all for the talk. On the wish for more psychedelic experiences from patients, obviously harm reduction is a good approach, I would also say. And Andre Jung-Able made the point that psychedelic therapy has a notion of self-empowerment in it. And perhaps this could be true also for a non-clinical setting. So what role do you think could maybe the social system or psychonauts or generally experienced people from non-clinical settings have? I'm also thinking of maybe psych-care from festival settings.
I think that's a difficult question. Simply, when looking at the indication we are talking about, treatment-resistant depression, most of them are chronically ill. And I think with this, also at the topic of like inner healing experience, I think that all kind of dips into the topic of, do you have enough resources to cope with whatever comes up in that upcoming psychedelic experience outside of a controlled setting? And if you do have enough resources to carry that destabilization yourself, then I think, that might be a good idea, but that's the challenge, to assess that. And I think that's also kind of the responsibility you as a practitioner have, because it is risky to do it on your own. Even if you anticipate, well, I'm well, you can never really know what comes up and if you are able to carry it.
Okay, I think that's it for the first part. So thanks a lot.
And so I will take over as the moderator. And I'm very, very happy to introduce my dear colleague, Dennis Scharf. He's a resident physician at the Central Institute of Mental Health, working in the department of Professor Gründer. We have been co-working in the EPIsoDE trial from the beginning. And I'm very happy that we're sharing this symposium together, and he will talk about adverse events, which is, I think, one of the most important topics in this field because the research is so limited.
Thanks, Leah. Adverse events, most important topics, you said. To be completely honest, the first time I heard the term adverse events, I thought, okay, this sounds rather boring, not really interesting, but maybe that's just me. Today, I think I have a different opinion today, and I want to show you why. So, trials, tribulations, and insights. Since we are in a trial here, at least in my mind, you are the jury, and I want to start with a rather bold claim. And for this claim, I want to ask Mr. Brexima to the witness stand, and I'd like him to tell us what his opinion is on adverse events. So Mr. Brexima, he published a paper just 1 year ago. It's called Adverse Events in Clinical Treatments with Serotonergic Psychedelics and MDMA, a systematic review. And I want to quote Mr. Brexima, and I'm sorry for mispronunciation. He says, quote, "Only few studies assessed adverse events consistently or systematically. Unfortunately, this is a general problem in psychopharmacology and not unique for psychedelic drug studies. Instead, most studies relied on spontaneously reported and/or therapist-observed adverse events. Spontaneous reporting depends on individual and contextual factors, enabling patients to recall or discuss negative experiences. Therapist observation is similarly ambiguous, as observations may be colored by their subjective perception and interpretation." The systematic review he didn't include the EPIsoDE study, but just by reading this, I already feel guilty, to be honest, because I think he's right. Yeah. But let's go back for a moment. Adverse events. What are adverse events? So the definition is any unfavorable, untoward, and unintended event, meaning sign, symptom, or disease, doesn't really matter, temporarily associated with the use of a medicinal product, whether or not related to the medicinal product. Okay, unfavorable, untoward, unintended, temporarily associated, and at first it doesn't matter if there is a causal relationship or not. We've got adverse events and we've got serious adverse events. I will come back to this in just a minute. Then we've got adverse reactions. This is what we call side effects. If someone is talking about side effects, what they mean are adverse reactions. And this is the same like adverse event, but this time there is a causal relationship between the event and the medicinal product. At least a causal relationship cannot be ruled out. And again, we've got serious adverse reactions. Okay, to be a little bit more specific regarding the time window, the time frame, there is another term called treatment emergent adverse events. And that's basically just defining the starting point where we start to watch. So if an adverse event, if the start date of this adverse event is on or after the date that the intervention began, it is treatment emergent. Okay, and last but not least, severe doesn't equal serious. So severe meaning, is it like mild, moderate, or serious? Mild, moderate, or severe. And serious, standing for this adverse event, is life-threatening. Maybe it even results in death. It requires hospitalization or results in persistent or significant disability, maybe even birth defect or other congenital anomalies. Okay, if this is the case, it's serious. So let's talk about challenges. Why is it so difficult to have standardized systematics regarding the assessment, the collection of adverse events? Well, unfavorable, untoward, and unintended. Where does this begin? Where does it end? It's not that clear, is it? I talked about causal relationship, but how do we really know if it's drug-related or psychotherapy-related, maybe a mix, or maybe something completely different, what has an impact on the person? We had persons laying in their bed during the session for 6 hours, and yeah, they didn't move that much, they didn't speak that much, so we've got no idea what's going on, what are they experiencing. So it's always difficult to record what's happening on a subjective level. Lea mentioned that psychedelic experiences are often ineffable. So how do you describe your experience if you're missing the words? And how are we supposed to assess if this is an adverse event, right? So yeah, common language. We've got different professional backgrounds. We've got psychiatrists, neuroscientists, and psychologists. So different backgrounds, different levels of experience, people starting their career, others with decades of experience. And yeah, this is a challenge. All of this is really hard to get this all in just one study site. But now imagine you've got study sites all around the globe. This is a challenge. So long story short, Brixema has a point, and I think we should talk about it. So I give you an example. This is a quote from one of the patients of the EPIsoDE study, and probably he was under the influence of a high dose, 25 milligram. We don't know, but see for yourself. So he said, I quote, "I saw the faces of my parents, first as I knew them as children, and then in a rapid aging process, to the point of decay as the flesh rots from their faces." This sounds really terrible. I found that extremely depressing, watching my parents age and die. So yeah, unfavorable, untowards, unintended. Yes, all the boxes are checked, right? The whole thing had an arc towards the positive at the end. That's nice. That's lovely. I can now watch my parents aging and dying and accept that as part of life and not as a completely horrible idea. Okay, so good. But what is it? Is it good, bad? Should we try to enforce this kind of experience or avoid it at any cost? Is this an adverse event? And once again, or for the last time, I'd like to ask Mr. Brixema and call him to the witness stand, because in the same paper published last year, he said the following, quote, "Some aspects of the definitions of adverse events are ill-suited in the context of psychedelic treatment. By definition, adverse events are undesired and something to be avoided. Categorizing challenging but potentially therapeutically beneficial experiences as adverse events can thus be counterproductive." Yeah, okay. But what about our patient? The patient described having benefited enormously from the treatment, being symptom-free for the first time in 25 years. Obviously, I'm cherry-picking. This is not standard, but nonetheless, this is one of our 144 patients. Okay, so let's have a look at adverse events regarding clinical trials with psilocybin. I just want you to focus on the right column, and there you can see like the total number of different individual adverse events mentioned. So for example, we've got 3 at the top, right? For example, headache and nausea and anxiety. If only those occurred or are documented, there are 3 adverse events in this trial. But as you can see, there's a large range from 3 up to 14. And even if you look at the numbers, how many participants are in each trial, there's not it's not clear that many participants equals many adverse events. It's not. Yeah. So I just want to point this out to give you this information. What are the most common adverse events? Well, headache occurred in all of the trials I showed you before. And if I remember correctly this morning, regarding the results of USONA, headache, nausea were mentioned too. And yeah, it's the same here. We've got headache, anxiety, and nausea. Those are our top three. And then beginning from rank 4, paranoia, all the way down to migraine, only 3 or 2 studies are mentioning them as adverse events. It's just an information. Now I'd like to show you some numbers of the EPIsoDE trial, but please keep in mind, this is not final. We are still not in the middle, but at the end of the study, and there hasn't been any analysis done yet. So yeah, be careful. We are supposed to give a list of all adverse events on a regular basis to the so-called Data and Safety Monitoring Board. And this happened the last time in May this year. And I saw this list. I took a look at this list. It has been 33 pages. 33 pages. And on those pages, 524 adverse events are in total. And if you look through all those adverse events, there are 115 different individual terms. Like, for example, headache is one of those 115. But again, it's adverse event, it's everything. It doesn't mean that there has to be a causal relationship. It's just what we collected, 115. Of those, more than half of those only occurred once. So, for example, one patient had a hematoma, one patient had a vaccine side effect or colon cancer. And I think I'm pretty sure that this has nothing to do with psilocybin, that there's no causal relationship, but still we need to report it, right? Okay. This is our top 10. And again, like in other trials, headache and nausea are right at the top. Of those 524 adverse events, over 100, I think 109 times it was headache. So headache is by far most common until now. And yeah, for example, common cold or diarrhea, not one of our patients had diarrhea during the session, and not one developed a common cold during the session. But in total, it happened during the trial and more than once, so that's why it's here in our top 10, in our preliminary top 10. Okay. I told you I feel guilty. Nevertheless, the EPIsoDE trial isn't included in Prexema's work from last year, but standardized collection or assessment of adverse events, it doesn't exist yet. So what we as a team thought was it would be nice to have some kind of list with at least the most common adverse events in psychedelic sessions, and yeah, to get a little bit more order, systematics, whatever. And that's why I'm happy to introduce SCAPES to you. SCAPES is an acronym standing for Standardized Collection of Adverse Events During Psychedelic Sessions. And what we did was we took all the adverse events already known from other clinical trials regarding serotonergic psychedelics. We had a look at our findings, what adverse events are maybe episode exclusive. And then we took the AMDP system, standing for assessing and documenting psychopathology, as like a basis construct. And yeah, we built scapes, right? So what is scapes? What does it look like? I'll give you an example just on the next slide. Right now it's 12 pages, pre-selection of all the AIs, I told you before. And because a common language is really important, we thought maybe we should write a comprehensive and comprehensible glossary too. So it's supposed to be included, that everyone, no matter how experienced or unexperienced they are able to fill in the same adverse events. And it's rather easy to use, so this is nice too. So I want to show you two examples. Nausea, right? Nausea is in almost every clinical trial regarding psilocybin. If nausea occurs during your session, you as a therapist, you just mark the box, okay, feeling nauseous, okay, when did it start, when did it end, what about the severity, was it like mild, moderate, severe, was it even life-threatening? If so, automatically, per definition, it's a serious adverse event, and then you just check the box regarding the causal relationship, and yeah, maybe do we need to intervene? Are there any countermeasures we had to take? And what is the outcome? So this is an example for a little bit more structured, maybe easier, because you just have to go through the list, think about, okay, did I forget anything? Did I remember all? And then you make your marks. The results from Usona. I heard 3 adverse events, at least mentioned: headache, nausea, and visual or optical, I'm not sure, disturbances or something with optical. And I would ask, okay, that's interesting, but what did happen? And here is an example. So you've got this field of perception, right? And then you decide, what is it? Is it an illusion? Is it a hallucination, pseudo-hallucination, or a synesthesia? What is it? And maybe you need to specify it. Maybe you need to look it up to get the definition right. But yeah, that's just one proposal to get a little bit more systematics, more clear, good data in order to assess psychedelics in clinical trials. Okay, thanks a lot.
Thank you, Dennis, for this interesting presentation, although it might be a dry topic for some people. And also to give us some insight in like, what are we actually doing when we're doing clinical trials? Like, collecting specific data like this is part of the game. Are there any questions? I'm running, please bear with me.
Hi. Wow, such an important topic and such a valuable contribution, the side effect, this attempt to qualify the side effects. Actually, I find a link between both talks, that maybe what's coming out, what's being published, doesn't fully capture the complexity of the therapeutic work, because the adverse effects, okay, headache, nausea, that's not so difficult, to manage. But actually, we're managing really, really deep emotions and difficulties. I wonder if the adverse event, untoward or unfavorable, but you've said that you can't classify it as that because the overall trajectory is positive. But somehow culturally or societally we say, okay, the patient was joyful afterwards, that's positive. If they were sad afterwards, that's negative. And so maybe so the question is, maybe adverse event isn't the right term for this type of classification. Maybe it would be something, I don't know, like therapeutic challenge or, that would capture it. Yeah, they wouldn't necessarily follow that cultural idea of, okay, happy, good, ontological shock, confusion, bad, or untoward.
Yeah, when I created those slides, I thought about, is this another example for psychedelic exceptionalism? You just can't, the definition of adverse events doesn't work here, it's exceptional. I'm not saying this, but at the same time, yeah, classic definition, it's something undesired, you need to avoid at all costs, doesn't work too. So I'm with you. Maybe we need another explanation or definition. Yeah.
And maybe I would also add that I totally agree with what was said, but in terms of what the regulators want, and we have to stick to the terminology and the classifications they use to some extent, although we also appreciate the limitations.
Thank you for your talk. And I just want to have a remark on the patient who saw his parents being born and aging. This is a very severe and daily practice for every good Buddhist to see himself and his beloved going the circle. And so you could also say, what a luck that this was experienced, because this is reality. And the question is, why are we afraid of that? And this is what has to be discussed, and not feeling like maybe this is an adverse event or a feeling of guiltiness, because reality appears. This we have to handle, and then we will live better, I guess.
I totally agree. You said this is reality, but I think at the same time it's like a clash of different people, different persons have different views regarding reality, right? So, for example, not everyone is familiar with the concept of Buddhism. So for them, it's maybe more like adverse. You need to avoid it. This is the problem we face.
Maybe also to add, I think in that example, it was important how the patient evaluated it. And for him, it was depressing and anxiety-inducing. And that's the part that makes it an adverse event in that definition. But that's the whole point of the discussion, right? That it's kind of a long-term, short-term thing. And in that moment, it is experienced as adverse. It might not even be, even though we regard it therapeutically as it might be valuable in the end, but we don't know. And but that's the whole struggle in this.
Thank you very much. I was wondering if you could talk about some of the factors that you might have seen popping out more. Are there any factors that come to mind when thinking about predicting who won't have adverse effects of one kind? Or then the other question would be the factors that might raise the chances of adverse effects, especially maybe more towards the psychotic area?
This is a great question, but I think I have to excuse us as a team because we are not at this point of doing the analysis. We have a lot of theories, we are talking about it a lot. So basically we are asking the same questions. That's what I'm saying, but I don't want to tell you something that maybe is not valid enough. So I'd rather not answer this yet, but give us a few more months.
Hi, I have been with the psychedelic work for 40 years, and I greatly appreciate your dilemma coming from the medical model and the German regulations around these studies. I also see that you are the Zentralinstitut für seelische Gesundheit. And that is a great title. And then doing this kind of study is very reductionistic. In my clinical work, for example, nausea, I tell the people I work with, and I know all these people individually because I do therapy for at least a year before, that when they feel nausea, nobody wants to throw up. But the kind of throwing up you do during a psychedelic journey is the best one you can imagine, because you throw up a part that you ingested in childhood and it is gone. And I was thinking just about a client, she suddenly felt nausea, threw up spontaneously, and I always have a bucket right there. And she said, this was the best throwing up I've ever done. And I just realized my mother was putting me up against my dad, and I started hating him throughout the divorce. And he did not stop me from being so angry at him because he was asking me to punish him, and that the guilt he felt about getting divorced. And that was the moment of throwing up. And the liberation that came out of that moment was amazing. I'd worked with this woman for 5 years before, and she changed, and she was free of that inner conflict that she had been holding for both parents. And another important thing is, like, when people get very cold and they ask for, 2 more blankets, that's also a sign that they are just approaching something that they are trying to avoid. And then helping the person step by step move into that cold feeling. And then the breakthrough occurring on the other side is that there was nothing to be afraid of. So the intensity of the therapeutic work is enormous. And I have great admiration for you guys trying to squeeze that into a scientific study. That is very, very difficult.
Yes. It is. Thanks. I just wanted to add, I thought about adding the example of the cleansing regarding ayahuasca, right? It's vomiting or even diarrhea. It's sometimes seen as an important cleansing part of the experience. So yeah, it's difficult, it's complex.
Okay, actually we're out of time. If it's really important, we can take that question, or we, oh, okay. Yeah, then maybe go ahead.
So we now heard about like the Buddhist perspective, and of course, I would say aging is a reality, and dying as well. It's part of being human, and this liberation, it is part of this narrative that there is no bad trip, or it could easily become this narrative, and that everything is just a challenging experience. And I just want to add my 2 cents. I think even though reality is, so aging and dying is part of reality, and there might be liberation in throwing up, I think this doesn't negate the possibility that there is just a bad trip and no medicinal value and no therapeutic value in such an experience. Of course, it's good to look for it, but I think it's still possible that there could be just no value and that it was bad.
Yes, I very much agree, and I think we just need to study it systematically to understand that better. Okay. Then we come to our final talk, and I'm very happy to introduce Manuela Brandt. She's a clinical psychologist, licensed psychotherapist in Germany, and she has also been with us right from the beginning of the study, being our most experienced psychotherapist. She has a master's, diploma psychology, which is the former master's degree in Germany in clinical psychology from Mannheim University, and also a degree in psychotherapy from Bern University. And beyond all that, being a therapist in our study, she's also head of our integration or post-trial integration group, which she will also dive into a bit more in our talk. So welcome, Manuela. Yeah, so for this last part of our symposium, I want to talk a bit about the concept of integration of psychedelic experiences and just highlight some theoretical and practical aspects that we in our research group found important. First of all, what do we mean when we speak of integration? I mean, generally in the psychedelic community, there is this understanding that when we do psychedelic therapy, that we have about like 3 phases of therapy. First, the preparation phase, where we, for example, inform patients about possible effects of the substance, speak with them about very relevant biographic aspects in their life and so forth. Then the psychedelic experience itself, and finally the integration phase follows, where broadly speaking, patients make sense of and learn from their psychedelic experience. It's important to always be aware that these 3 phases are not that they are interdependent, and each of them have an important influence on the course and the direction and the outcome of the psychedelic therapy. And when we look at the integration, maybe we can broadly think of 2 types of integration. On the one hand, we might want to maximize benefits. For example, if a patient came to great insight during their psychedelic experience and wants to deepen, explore that further, or make any changes based on that in their lives. And then also the minimization of harmful effects. For example, if a patient comes out of the psychedelic experience with a heightened sense of vulnerability or anxiety that doesn't subside, and we see how we can help them deal with that or get out of it. Keeping in mind all the complexity of what we just discussed about adverse effects. The first one, maximization of benefits, we find is more relevant to the efficacy of the therapy. So we try to acquire or maintain or boost the effects of the therapy. And the second, when we try to minimize harmful effects, is most relevant to the safety aspect of the therapy. Even though within the psychedelic community it's agreed upon that integration is very important, there's still, in comparison to the other 2 phases just mentioned, much less literature. We have very little literature or research on underlying models, theories, or even the
techniques themselves that might be useful. I would like to offer a scientific definition that came out last year by Bhatia et al. They looked at 24 different distinct definitions of integration and came up with the following one. Integration is a process in which a person revisits and actively engages in making sense of, working through, translating and processing the content of their psychedelic experience. Through intentional effort and supportive practices, this process allows one to gradually capture and incorporate the emergent lessons and insights into their lives, thus moving toward greater balance and wholeness, both internally and externally. I would like to add that obviously this process can happen alone or supported. It might take days to months if we look at a formal idea or definition of integration. So when we think about it in a formal setting, one can say that the integration phase ends when the contents of the integration session no longer deal with the challenges and questions that arose from the substance experience. Now, obviously, this is, again, artificial in a sense, I mean, as maybe comes across with this more metaphoric definition. Yeah, when we use the word to integrate generally in daily life, we usually mean the joining together of parts that need to be together, or we add missing parts to something so that we achieve some sort of completeness or wholeness. And therefore, I like the definition that was put forward by Ike Sala last year in his book, Psychedelic Integration. It's one of the metaphors that the psychedelic experience can be seen as a puzzle piece that needs to be incorporated into a previously existing mental map, as illustrated by the puzzle image here, where the psychedelic experience can be maybe a piece of the puzzle that fits maybe relatively easily, but it might also sometimes, especially when there are transpersonal levels involved in the experience, be of a totally different shape or color at first sight, and therefore be a bit more challenging to integrate. Interestingly, the word puzzle also stems from the 16th century English term puzzle and means to be wilder, in German verwirren, or to astonish, verwundern. And I think still that is also meant in the English language today when people say I'm puzzled. So I kind of find that fits well to the psychedelic experience that often shows us that we don't even know how many puzzle pieces are there, how big is that puzzle, what are we actually coming to build here. So in a broader sense, obviously one can ask that question, is there ever an end to integration? And it's probably not. And nevertheless, we still try to formalize and define some of those challenging, non-definable aspects of this psychedelic therapy. Yeah, let's move on to some of the practical aspects. So what about integration in a clinical trial? I mean, as we heard from Lea before, we are dealing with a study design that is based on older study designs that have been developed to test substances with simple change mechanisms. We have, yes, obviously very little time for psychotherapy in comparison to a possible ideal outpatient treatment. We also deal with a very specific patient population in our study that I would like to illustrate by showing you some demographic variables. In preparation of this talk today, I did look at some of the variables and demographics of the patients that I accompanied in my role as therapist in the study. They refer to a subsample of 20 patients. Average age was 41 years. You see the variance in brackets. There were 13 men and 7 women. And just some things that stood out in our interaction with them. If you look at relationship status, you can see that 60% of them were or are single at the time of the study participation, and 65% of them had no children. I did compare that with some data from the Federal Bureau of Statistics in Germany, where for both those variables, you'd have about 20% in the general German population last year. So when we look at some of the characteristics of that so-called therapy, treatment-resistant depression, we can see that the average of time since the diagnosis of depression with them was on 11 years. When you speak to them, obviously you realize that often it's more, because many of them have experienced symptoms already since youth. That was just not yet clear what it was or was in development. Then on average, they had taken 4.6 antidepressants. They were hospitalized for psychological treatment 1.6 times on average, and they tried on average about 4.5 other types of treatments, including all kinds of treatments like psychotherapy, RTMS, holotropic breathing, and others. In a life questionnaire, they rated themselves that on average they'd spend about 72% of their time alone rather than with others, and only 25% of them were working full-time at the time when they participated or entered the study. In comparison to general German population, I would be of a similar age bracket of 15 to 65 years, there would be 66% of Germans in 2020 who worked full-time. I would also like to point your attention to a questionnaire that we use that also provides a relevant insight into the TRD population. The Childhood Trauma Questionnaire is a retrospective self-report measure that provides a brief assessment of a broad range of traumatic experiences in childhood. There are 5 scales: emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. Just some examples for questions that are contained within it. For example, a question: during my childhood and youth, I had the feeling that someone in my family hates me. That would be an example for emotional abuse. Or during my childhood and youth, did we as relatives feel close? That's an inverted item for emotional neglect. Or I had to wear shabby or dirty clothes. That's physical neglect. The answers range from not at all to very often. And looking at those 20 patients, I just plotted here. You can see each patient with their highest score on the CTQ, meaning that they at least would score on one of the scales in these categories. So 2 patients only were completely unobtrusive on this scale. 6 patients had at least one scale where they experienced low to moderate traumatization in childhood. 5 of them moderate to severe on at least one scale, and 7 of them severe to extreme experiences. So then also, if we look a little bit more in detail, then, I mean, we obviously do screen for PTSD. If someone had a diagnosis of PTSD, they would not be allowed access into the study. So, for example, physical abuse or sexual abuse may be as experiences that are more likely to develop into a PTSD diagnosis. They didn't score that high on them, but more on the scale emotional abuse and emotional neglect. They were the most, like 14, for example, of the 20 patients scored on emotional neglect. And interestingly, also a lot of the intentions, when we speak about intention with the patients before the treatment, evolved around emotional topics, like, for example, the intention to reconnect with emotions. So yeah, this is just interesting for now, without having run any analysis or anything on that yet. So the question obviously is how can we best help these people if we consider the limitations of study design with a distinct start and end point, a possible intense intervention, the relevance of a strong therapeutic bond, and the relevance of integration. So we did we did start an integration group. I'm showing here what we did in Mannheim. Our Berlin colleagues have a different concept. We called it EPIlogue because the term epilogue comes actually from theater or literature, where the epilogue follows after an actual action has been completed. It can be an afterword or closing speech and contains thoughts, topics that have not been adequately examined. It may include thought-provoking interpretation and explanation and can provide space for the personal dedication of the author. So that was related to what we wanted to create with our integration group, which happens actually after the end of study visit. So it doesn't influence any core element measures of the study, but we wanted to provide a space for people to deepen their integration of the psychedelic experience. We also wanted to be able to provide further space for questions, to help them with what we call in German Psychoedukation, space for feedback, ambiguities, also for them to exchange, to find a place where they can be in contact with other participants who have experienced this psychedelic experience within the study context, because many of the people don't know spaces where they can actually talk about this. And then also we wanted to just provide more time for the therapeutic relationship to maybe fade out in a more natural way, not by a cut-off date at a certain point. What we, however, did not intend with it was a replacement for psychotherapy or treatment of symptoms. So we would try to recommend to them further treatments, outpatient treatment or other clinics if they needed further treatment, or if a long-term intense treatment was necessary. The format was that we had we did it online because the patients come from many different places all over Germany. And we said that they could come for at least 6 online meetings, depending on the size of the group. That would take place once a month. We'd have one stable therapist overlooking the overall process. And then we would have a rotating system so that we are 8 therapists in the study. And each patient obviously had a specific team of a man and a woman accompanying them, providing the psychological support throughout the study. And we wanted everybody to be able to also obviously reconnect and see their therapists again. Twice a year, we also hold an in-person meeting at the Central Institute. And there we have a big group. Everybody who finished the study can come, and all therapists are there. And we also provide a bit more practical, for example, exercises for integration and other things. Yeah, this is just a little bit more on what we actually do within the group. It's based on a concept of Fiedler, an open-ended, interactive, solution-oriented concept. We have, I'll just go a little bit faster. We have 90 minutes in total. First, we do an opening round just to check in with everybody where they're at and maybe clarify some organizational things, feedback, and so forth. And then the main part of the group is actually the individual casework, where each time on a voluntary basis, one patient presents to the group a part of their psychedelic experience, or maybe their whole experience with the study, how much they can feel like they want to share or are able to share. And then the group members serve as co-therapists, so us, we go a little bit more into the background, we just see that everything runs smoothly and help along the way if needed. But actually we want to promote the group therapy elements that Yalom pointed out for allowing the group members to help each other and to experience the universality of their topics, etc. So then the group asks questions about that description of the experience by the patients, and then themselves also in the third part provide feedback. Maybe they feel they can relate to what the index patient described. So yeah, we kind of allow them to go into this therapeutic role, and it has been very interesting to see how they support each other. Yeah, that's, I think, roughly the most important about a brief introduction to what we're doing. We haven't run any analysis on it yet. We were looking forward to seeing what happens. It's more than half of participants, I can say, that come join the group. And it's very different. It's not that we kind of get the feeling it's only people who are very happy with the treatment or with the experience, or people who are like, it's very mixed with what kinds of intentions the participants come to the group. I think I'm ready to take any further questions.
Thank you, Manuela. I do see questions. Thank you. So I come across this issue. I don't provide therapy with psychedelics for obvious reasons, but some of my clients do this on their own and then come back. And I was wondering whether the methods that you use in the integration process, do you see the potential that right now people like me could use what you do with people after they had a psychedelic experience, so that I could get some help and guidelines into how to better also do harm reduction if there is harm? So that would be my question. How open would you be to sharing that? Because this is a very burning need for me as a practitioner.
Yeah, thank you. I'm not exactly sure now what your profession is and what. Okay, yeah, I mean, is it sufficient if I say, yes, sure, just contact me after the talk and I'll be happy to share anything I can share. Mm-hmm.
Thank you very much for bringing more psychotherapy into this field. I'm working in Switzerland, and my head doctor is also serving as a therapist in psychedelic sessions legally. I have two questions. The first one being, do you think that the person applying the substance and doing the integration should be the same person as the long-term psychotherapist? And secondly, did you talk to the psychotherapists of your study participants to get feedback on how they integrate it in their regular psychotherapy?
Yeah, I mean, we are always happy when our patients are already in some form of outpatient treatment, and we always offer that we are available for a telephone call after the end of the study so that we can communicate and build a bridge towards their outpatient treatment afterwards. And the first question was, we believe ideally yes, because in the ideal situation you build a positive, a strong therapeutic bond, and you go through a process where that plays a key role for the healing process. So it might even potentially be dangerous or negligence if there is someone else coming in with no idea, even though obviously, one could also say it's better for someone to tend to the person in their process than if it doesn't happen at all. So maybe in the ideal case, it could be a continuous process, if also desired by the patient, because after all, we also follow always a patient-led approach. So if the patient, for example, has the wish to go to somebody else, of course, we also support that. So I think it's the answer is one would have to look on the individual case and then see what's best for them.
We would have time for one short question, if there is any. Okay, then.
Yeah, I have just a last remark. I just want to say thank you to the patients that were represented here in our presentation today, and thank them for the trust and the courage that they bring into the participation here in the study. And then I also want to thank the whole team, both present here and back home, for the great privilege to working together, because none of what we just showed today, all three of us, would be possible, without this big group of great people.